This systolic ejection murmur reflects turbulent flow across the stenotic aortic valve. In contrast to an innocent murmur, this murmur peaks late in systole. Notice the late peaking of this murmur. Innocent murmurs reflect a normal flow velocity profile across the aortic valve. Aortic stenosis, on the other hand, has a delayed peak, reflecting the increased obstruction to outflow. Notice how the innocent murmur peaks early in systole, and compare that to the late peaking of aortic stenosis. First, the innocent murmur, and now aortic stenosis. The presence of an ejection click localizes the obstruction to the valvular level and strongly suggests the presence of a bicuspid aortic valve. I will begin with normal heart sounds and then add the ejection click and then the murmur of aortic stenosis. Pathologic murmurs secondary to obstruction across the left ventricular outflow tract can occur at the subvalvular, valvular, or even supravalvular level. Notice the ejection click that initiates this murmur. With significant aortic stenosis, the carotid upstroke may be both delayed and diminished. The murmur of aortic stenosis will, on occasion, be audible at the cardiac apex with a change in pitch, the Gallivardin phenomenon. Despite this increase in pitch, this murmur retains its characteristic diamond shape. Listen to this murmur first at the second right intercostal space, and now at the apex. Although stress testing is contraindicated in symptomatic patients with aortic stenosis, it has been safely performed in asymptomatic patients. As many as 1/3 of asymptomatic patients will demonstrate symptoms or abnormalities on exercise testing that may warrant valve replacement. Listen to a patient with combined aortic stenosis and regurgitation. I will begin with the systolic murmur and then add the diastolic component. Patients with aortic stenosis and a low ejection fraction are problematic. One way to identify those patients who will respond well to surgery is pharmacologic stress testing. If their gradient increases significantly with dalbutamine infusion, then these patients are acceptable candidates for surgery. Listen to a patient with aortic stenosis and both a third and a fourth heart sound. I will begin with the fourth heart sound, then add the third sound, and finally the murmur. Recently, percutaneous aortic valve replacement has been introduced. Clinical trials, still in progress, will reveal the indications and benefits of this exciting new approach to aortic valve replacement. Echo Doppler studies can define valve anatomy and function, allowing a calculation of both valve gradient as well as valve area. In summary, aortic stenosis usually presents with a late peaking, diamond-shaped murmur heard best at the second right intercostal space. When this murmur is accompanied by an ejection click, it suggests a bicuspid aortic valve. Listen once again to the murmur of combined aortic stenosis and regurgitation. This high-pitched, blowing, diastolic murmur, heard along the left sternal border, is typical of aortic regurgitation. Notice the decrescendo nature of this murmur. This murmur gets louder with an increase in afterload. Notice the change in this murmur with a hand grip maneuver. Rest. Hand grip. This murmur has a pitch similar to respiratory sounds and can be overlooked unless the clinician listens to the patient in held expiration. Notice how much easier it is to hear this murmur with held expiration. Breathing. Held expiration. Rupture of an aortic cusp can result in a cooing dove murmur. This type of murmur has a unique auditory signature. In severe aortic regurgitation, there may be early mitral valve closure, resulting in an Austin Flint murmur. Although similar to mitral stenosis, this murmur is introduced by a third heart sound, and the first heart sound may be normal or even diminished. Listen to an Austin Flint murmur. I will begin with normal sounds, then add the third sound, and finally the Austin Flint murmur. A systolic murmur is common in patients with moderate to severe aortic regurgitation. This murmur results from the large stroke volume ejected across the deformed aortic valve during systole. This murmur typically peaks in the first half of systole in the absence of significant aortic stenosis. I will begin with the diastolic murmur and then add the ejection murmur. In patients with both aortic stenosis and regurgitation, the systolic murmur usually peaks later in systole. I will begin with the systolic murmur of aortic stenosis and then add the diastolic murmur. If aortic regurgitation is heard to the right of the sternum, then aortic root pathology, such as an aortic aneurysm, should be suspected. Just before heart failure develops, patients with significant aortic regurgitation should have their valve replaced. Many cardiologists follow the 55 rule, recommending valve replacement when the left ventricular end systolic diameter reaches 55 millimeters or left ventricular ejection fraction falls below 55%. Aortic dissection can result in acute severe aortic regurgitation. In this situation, there is decreased forward stroke volume, resulting in pulmonary edema and sometimes cardiogenic shock. The arterial tree clamps down and prevents the wide pulse pressure normally seen in chronic aortic regurgitation. The absence of this common sign can make it challenging to diagnose acute severe aortic regurgitation. In summary, aortic regurgitation typically presents with a diastolic decrescendo murmur, which is heard along the left sternal border. Acute aortic regurgitation can occur as a result of trauma, endocarditis, or aortic dissection. Listen once again to the sound of severe aortic regurgitation.